So just this first slide, I just put it up because we talk a lot about personalized medicine, but to Joe Biden, who's leading the cancer moonshot, former Vice President of the United States, for him it was also a very personal thing because his son had died of cancer. And I think it's very important to remember that in the context of how we actually work together. We must always be putting the patient at the center of the process. And this Cancer Moonshot is an initiative that's been driven to the United States, but I'll also talk about some international initiatives where Europe is playing a very important part. And the other thing, just in relation to precision medicine and personalized health, particularly in cancer, the drugs do work, but it's not just the drugs. And as we've heard already in relation to prevention, HPV vaccination, despite the naysayers, is actually something that's very effective. It actually cures a cancer, so this allows you to cure cancer. We've already heard quite eloquently from the previous speakers on SABRE in lung cancer and also on Da Vinci. And then yes, in precision oncology, we do have some very good examples of the type of approaches that we can use to really target particular abnormalities that are seen in cancer patients. The other thing to remember is we also need to back up that with things like diagnostics, precision pathology, and as I said, patient participation is very important, and I'll talk about a very interesting example of patient involvement in precision care slightly later on. And I'm a big data geek, so one of the things I really feel is that we really need to use the value and release the value of the data for patients. The other thing to remember is that radiotherapy and surgery actually cure far more cancer patients than does chemotherapy or targeted therapy. So we're talking about precision medicine as a nuanced added value when we're actually seeing it. So we heard quite eloquently, particularly from the first speaker, combining, for example, radiotherapy and immunotherapy is a very exciting area where we're going to see, I think, big advances in the treatment of cancer. The other thing is we need to use that knowledge of the patient not only in terms of trying to affect cure, but also in looking at increasing and improving quality of life. If you talk to a cancer patient, that's equally important and sometimes more important than the actual effect of the therapy in relation to getting rid of the cancer. But yes, we have seen significant changes in this era of precision medicine. And I suppose the two best examples that really are now at sort of widespread use, as Mary said, I used to work in Trinity College and St. James's Hospital. I was in the National Bone Marrow Transplant Centre. Pre-2001, we would treat patients with chronic myeloid leukemia with allogeneic bone marrow or peripheral blood stem cell transplantation. Post-2001, we used this drug here, Gleevec or imatinib mesylate, and that changed practice. You can say that 2001 actually changed the practice of treatment for a particular disease. And Herceptin also changed practice in relation to ERB2 positive breast cancer. But I suppose the question I would ask, were we lucky at the start? Are these Herceptins? Because what we actually saw was that after that great promise in relation to these two approaches, some of the other approaches in relation to other targeted therapies weren't really as effective. And I think what you have to remember is that cancer is actually a very complicated disease. And sometimes you target one pathway, but the cancer is very clever and it actually just gets around that and goes to another pathway. And that's one of the reasons why some of these sort of early successes weren't maybe mirrored in other forms of cancer. However, we're starting to see like immunotherapy we thought was going to work 10 years ago, didn't really, but now we're really seeing that it is as we understand more about the biology of the tumor cells. The thing is, how do we continue to promote this innovation in a situation that has radically changed since 2008. So we really need to look at addressing this cost-value Rubicon, and because in order to do that, that really needs us to think about not only effective therapies, but also are they viable and are they cost-effective? And what value can they actually give not only to the patient, but also wider societal value? I think we'll all agree, certainly most of the people in this room that I've talked to previously would agree that cancer clinical trials as we did them before, pot A, pot B, and we mix them together and we look and see do we get a result, that is not going to work anymore. And we need to move away from this incremental model to a much more transformational model. The reason why we need to do that is because the patient is not affected by a p-value. The patient is affected by an actual change, either in relation to their quality of life, in relation to the response to therapy. And so we always need to remember that and not simply be fixated on an actual small change in the p-value that really probably doesn't make any difference to the patient themselves. So really, I really need to, to think about the evidence-based approach and also different ways in which we do clinical trials. We know historically, and also as we start to look at how we understand the biology of tumors, that really it is not one size fits all. And we often hear about the idea of getting the right treatments to the right patients at the right time. I would just put a small caveat into that. We should be trying to do that the first time. So not at the end stage, but actually at the beginning, because that's when we're actually going to see much more efficacy in relation to how we treat patients. As Mary said, I now work in the Centre for Cancer Research and Cell Biology in Queen's University in Belfast, and I specifically concentrate in the area of bowel cancer. I'm just going to take one example just to show of a number of the different programs that we're involved in, which is the last one there, the MRC Stratified Medicine program, which I lead in Belfast. And what I'm showing you here deliberately is a picture of all these people, because these are all the different people who are involved in this program. And they have different skill sets, because that's what we really need to do now. It's a team-based approach to actually try and combat this killer disease. And so we need to bring everybody into the picture. So what we have here are oncologists, radiotherapists, surgeons, patient advocates, nurses, geneticists, industry, patient advocacy, and health economics with Richard Sullivan. So really bringing that sort of broad stroke together, bringing all these different people together, is the way in which we actually achieve real progress. And really what we've tried to do with this is bring together in the UK, because this is funded under the MRC and Cancer Research UK, really the best of the UK in this area. So we've brought together all the colorectal people across the United Kingdom who actually would be recognized as being the best, because we need that type of expertise working together to solve some of the problems. The other thing is not only addressing key clinical questions in order to improve the patient's experience and the quality of life, and also to achieve greater cure rates, but also to build a legacy resource that other people can actually use, both in terms of samples, but also more importantly in relation to data. This just shows you the different institutions involved, the different companies involved, and the different patient advocacy and policy people involved. So that's really how you need to think about cancer now. It's no longer a single oncology discipline, it's actually a much wider discipline, and we really need to embrace that. And really what we're trying to do is employ disease stratification approaches, so to get to that situation where we can actually give the right approach to the right patient the first time, but also to look at making sure that it's cost effective and that we can improve and maintain quality of life for the patient. This just shows you one example of a trial. I'm not going to go to the detail of it, but what it does is it allows us our molecular understanding, so our genomic understanding of what is the particular abnormality in the patient, and that then drives what that patient will get in relation to the therapeutic. So for example, they have a PI3 kinase mutation, they'll have a particular therapy. If they're RAS mutant or RAS wild type, they'll get different approaches. We look at, for example, aspirin as one of the arms in this study. So this is a multi-stage, multi-arm approach, and really changes the way in which we do clinical trials. I'm just going to show one slide here. This is Philip Dunn, who's a very bright senior research fellow in my group. And what he has found, and it's just, again, I'm not going to show any data on this, so you just have to take my word for it. He has found that actually by looking at gene expression profiling, so looking at genes that are switched off and looking at a molecular snapshot, if you like, of the cell, that the expression of a particular gene allows us really to identify patients who shouldn't get chemotherapy, and that maybe an immune-based therapy approach would be better in this setting. And this got quite a lot of excitement. The American Association for Cancer Research featured it on their website as a sort of paper to read in this month. And so we're very excited out of that. Out of that, we've now developed a CRUK program that has just been funded to actually look at this in more detail. However, I did say I'd come to the data. I'm going to go back a little, and one of the previous speakers, actually, first speaker as far as I remember, referred obliquely to this particular slide. So this slide is probably the most famous X-ray in the world. And my question would be, yes, Sharing data led to new knowledge, the double helix structure of DNA. However, did Rosalind Franklin give her consent to Maurice Wilkins for him to share that picture with Watson and Crick? I think not. And if you look in the Eagle pub in Cambridge, where I was last Saturday, there's this plaque on the wall in the Eagle pub. And it says there, as you can see, we've discovered the secret of life. However, I didn't drink a toast to these two guys. I drank a toast to Rosalind Franklin, because she was really the catalyst that drove the discovery of life. And I think it's very important that we always remember that. So if we spin that helix forward to 2015, and suddenly I find a president who actually in his State of the Union address talks about science and personalized medicine. I don't think the current incumbent will even be able to spell that. But interestingly, if you actually look within his precision medicine initiative, he talks about a cancer knowledge network. And that's really an interesting concept and one that we're trying to drive forward. Because there's a challenge here, a data challenge that is significant. There's a data challenge in relation to scale. We're talking about large amounts of data that we collect, and we're continuing to, and we include, for example, patient-reported outcomes, as well as epidemiology, clinical, genomic, imaging, etc. But I don't think that's the problem. I think that's solvable. What I think the challenge is, and the main challenge that we face, is actually linking the clinical data to, for example, the genomic data or the epidemiological data. And that's where we really need to exercise ourselves. And one of the challenges in that is clinical data, case notes in general, are not machine readable. So one of the things we need to do, particularly in cancer, is to have almost a lexicon or a series of dictionaries that actually, an ontology as we would call it, that actually allows you to capture descriptions of the physical expression of what cancer is, and then machine read that and link it to the genomic data. And that's something we've been working very closely with in an organization I'm going to mention in a minute called the Global Alliance for Genomics and Health. And we're actually learning from the rare disease community, because they do that all the time, because that's what rare disease is. You're actually looking at the patient and trying to look at what is the phenotype of the patient and then link that to, for example, a genetic mutation. Ethical issues are obviously very pertinent in this area, but again, I'm going to talk to you about how we've addressed this up front. Cultural issues are a bit more difficult. So this selfish silo mentality pervades academia, industry, and we really need to change that. People want to hold on to data, whereas actually they should be freeing it out there and making it work for itself. Because if you keep on using data, it's the data that it keeps on being valuable to you. And then also financial, particularly if we're talking about data sharing across countries, across continents, how do we do that? So I'm a member of the Global Alliance for Genomics and Health. It was set up in 2013 and essentially brings together, at this stage, from about 480 organizational members from nearly 80 countries at this stage, over 1,000 or nearly 1,000 individual members. So what are these? Who are these people? Who are they? So as you can see, they reflect a variety of different stakeholders. But the common thing is to try and effectively but responsibly share clinical and genomic data. And that's one of the reasons why I was in Cambridge last weekend, because we were actually meeting together to essentially plan our strategy for the next 5 years. But you can see there all the different groups, universities, medical centers, advocacy groups, consortia, funders, life sciences and IT companies, pharmaceutical companies, etc. And the reason why we've done this is because I would suggest that no single institution can go it alone in relation to data, but also no single country in certain situations. So this idea of sharing with each other, particularly if we think about cancer no longer as a common disease, but actually a series of rare diseases based on their genomic makeup. And so therefore we really need to, in order to get the type of information that we need that allows us to either develop a new diagnosis or a new therapeutic option, we really need to get that information together, share it and use it. And so what we've really done is try to embrace this idea of a data-sharing cancer research cooperative, where we can nurture common data-sharing solutions and also look at facilitating our aim, this responsible but effective sharing of data. So one of the things we did last year, and we published it in Nature Medicine, was to develop a blueprint. And that blueprint has an ethical framework, and also a series of ethical steps that allow people to conform to ethical standards from across the world. Also looking at ways in which we can link the longitudinal clinical data, and thirdly, in relation to data warehousing and data access. In relation to the ethical challenges, we've set up a framework for responsible sharing of genomic and health-related data. We have policies, consent tools, etc., that people can freely use. One of the things I want to emphasize is what we want to try and avoid is the Tower of Babel. And I'll just show you this example. So this is an example of a series of about 12 different databases from around the world, specifically in relation to genomics. And what you find is, in their own right, these are all excellent databases. You go into them, you can get information, knowledge, etc. They're very easy to use. However, none of them talked to each other back in 2013. Thankfully, due to the work that we've done over the last 3 years, and this is particularly in rare diseases, but also developing in cancer, so by October 2016, so the first slide I showed you was from the American Society of Human Genetics in 2013, where essentially none of them talked to each other. You can see by 3 years later, they're all talking to each other. And so that's much more effective in terms of sharing that information. The other thing we provide is applied program interfaces, so things that actually allow you to actually use the data. We put them on the web, we make them open source, make them available to you. And the other thing we do is we make sure that we get around the problem in relation to data privacy, that rather than the data, for example, moving from one jurisdiction to the other, you port the informatics or data analytics solution to the data. So it's a subtle difference. You bring the solution to the data, you do the work, you then come out with that data, but that data is depersonalized, so there's no identifiers in it, and that way you don't have the data itself moving from country to country, the primary data. And so that just sort of emphasizes that, because it's a very important thing, because we need to be very rigorous in relation to data protection and in relation to the privacy of the individual. The other thing is patients want this. We've done a number of different surveys, and there's a very actually interesting survey that we're doing at the moment with the Wellcome Trust, but it's showing us that patients really want to share the data. They don't want to be passive recipients. They want to be active participants in this, and I'll show you an example in the next slide. But we need to respond, because otherwise their enthusiasm will actually waver. And this just is a great example. So this is, ROS1 is a gene that's mutated in approximately 1% of cancers, initially seen in lung cancer, but then also in other cancers. And we know that as a mutation, it's targetable by the drug crizotinib, which is used to treat patients who have another mutation in lung cancer, ALK-positive lung cancer patients. But no clinical trial was available for these patients who have the ROS1 mutation. So what did the patients do? They actually self-aggregated online. So 11 different countries, 120 patients in about a 3-month period, and from all over the world, Bangladesh, Brazil, Italy, UK, unfortunately not in Ireland, but certainly we're looking at working with people in relation to this. And what they did was then share their information and then approached the Bonnie J. Addario Lung Cancer Foundation, which is a foundation based in San Francisco. And they're now working with the Lung Cancer Foundation to actually develop a clinical trial. So this is a patient-led precision medicine approach, and I think we're going to see more of this in the future. So just as Mary said, we published them this morning in the New England Journal of Medicine, essentially a call to action. Because what we're saying is, this is critical to how we achieve things, how we move forward in relation to not only cancer, we're focusing obviously on cancer, but rare diseases, infectious diseases as well. We need to share that data, get it out there, use it effectively so that we can actually get that benefit and use that to transfer it onto patients. So really moving from that closed, selfish silo culture to a much more open source, collaborative culture. So rather than no can do, just again to steal something from Barack Obama, it's a yes we can culture. So a patient-focused informatics ecosystem where precision oncology, personalized health can seamlessly transition from cancer diagnosis through molecular discovery to patient recovery. That's really our goal. If we don't do this, I would suggest that rather than shooting for the moon, the data cloud that's on the horizon will cause us to fly too near the sun. And just again, talking about horizons, this is my favorite horizon. This is the Giant's Causeway up on the Antrim coast, just above Belfast in Northern Ireland. And again, sorry, but I'm also going to do a plug at the end of November this year, and you all have little bookmarks as well there on your tables. The European Alliance for Personalised Medicine are having their Congress in Belfast. It's an EU presidency event. Very importantly, it's the Estonian presidency, and some of you would have heard the Estonian Minister for EE Communications earlier on. And because Estonia have really embraced the whole data sharing, big data, and also genomics. And so I very much would like to welcome you to come to Belfast. This is going to be probably the meeting in relation to looking at how we actually develop and drive personalised medicine approaches in the future. Called Personalising Your Health, a Global Imperative. We'll have all areas, including agri-food as well, and nutrition and health, which again is a very important part. And also as part of that, we'll have a PPI, Genes at Queen's Day, for patients and the public as well. So thank you very much for your time, and very happy to.